In the last lectures, we have discussed the classes of hypovolemic shock. Now, how do we monitor a patient with class 3 hypovolemic shock? That's a very important concept for us to understand. There are two important points we need to know. First is the best indicator to determine the amount of fluid required in shock. And the second is the best clinical indicator of successful fluid resuscitation in shock. Now, what is the meaning of these 2 points? Let's come to the first point. How to initially determine how much fluid to give? The answer is pulmonary capillary wedge pressure, and the second is central venous pressure, CVP. So, for all practical purposes, it is the central venous pressure which is what we use to determine how much fluid to give. But theoretically speaking, pulmonary capillary wedge pressure is better indicator than central venous pressure because it gives you an accurate measure of the left-sided heart pressure, whereas central venous pressure CVP is giving you right-sided heart pressure. Now, we use a Swan-Ganz catheter to measure pulmonary capillary wedge pressure. Now, once you have given fluid, how do we know whether the fluid has been adequate or inadequate? And that is determined by the urine output. The urine output for adults should be maintained more than 0.5 ml per kg per hour, whereas for children, our aim should be more than 1 ml per kg per hour. Now, there are certain new endpoints of fluid resuscitation are added. The new endpoint of resuscitation for systemic perfusion is MBOS. This is mixed venous oxygen saturation. The second one is base deficit, and the third one is serum lactate. So these are the three for systemic perfusion, and if you have to choose a single base endpoint of resuscitation, that is MBOS, right? If we see for clinical endpoint, it is urine output. For muscle and brain perfusion, the endpoint of resuscitation are NIRS, that is near infrared spectroscopy, and tissue oxygen electrode. For gut perfusion, there are three of them: sublingual capnometry, gut mucosal pH, and laser Doppler flowmetry. Okay, so this is how we monitor a patient with hypovolemic shock. Now, there are certain indexes which I want you to remember. They have been used to monitor shock. First is shock index. Shock index is heart rate divided by systolic blood pressure. And the other one is modified shock index. Modified shock index is heart rate divided by mean arterial pressure. And the third one is ROPE, that stands for rate over pressure difference. So rate means heart rate, pressure difference means systolic minus diastolic blood pressure, that is pulse pressure. So heart rate by pulse pressure is ROPE. Now, out of these three, modified shock index is the most sensitive indicator. The important thing is, if you have shock index ratio of more than 0.9, then there is higher mortality. And if the ROF value is less than 3, patient remains stable. But if ROF value is more than 3, then it is indicative that the patient might develop decompensated hemorrhagic shock. Okay.